I will be updating you on small animal epilepsy. We've had a very significant last 6 months, and so I would like to welcome you all to this topic, as well as our online folks that are following on Twitter and possibly YouTube, I believe. So welcome all of you tonight. Feel free to interrupt me with questions as I go, and certainly at the end I will be happy to entertain any questions, including case questions. So without further ado, I'd like to introduce you to my team. This is my team. I work with Dr. Luis Gaitiro. He is a diplomate of the European College, who's been here for a number of years now. Jennifer Collins is our stalwart tech. She runs the neuro service. And with us this year, I have Tom Parmentier and Randy Cochran. Tom's our first-year resident, so he'll be a common face and voice for the next 3 years. And Randy is our neurology intern. We're very proud to say he's landed himself a residency in Missouri, and we're very, very pleased for him. I think that's a great step. So tonight's talk, obviously centered on epilepsy. I'm going to touch on 4 major topics: updates in terminology, diagnostics, breed-related material, and treatment. What has happened in the last 6 months, actually I think it was 7 months now, published at the end of last summer, was a proposal for veterinary consensus. And this is huge. I cannot emphasize how huge, because for years we've all been talking with disparate voices in veterinary epilepsy and following behind, about 20 years behind, where the human epilepsy folks are. And so a group of veterinarians, both specialists, GPs, pathologists, human and veterinary basic medical researchers got together and formed the International Veterinary Epilepsy Task Force and published a series of proposals for consensus on terminology, the diagnostic approach, genetic epilepsy in dogs specifically, neuropathology guidelines, and medical treatment and therapeutic outcomes. This came out in late 2015. I have read all these papers and distilled them for you into tonight's talk and the handouts that you received, including some tables that I found very useful, and hopefully you will as well, so you don't have to go wading through looking for them. I'd like to point out, though, that all of the papers I'm referencing tonight are open source, and this also is huge. This is a movement within the veterinary and human literature in the last few years to make our knowledge available to everyone. You don't just have to have a university account anymore, and so I'm fully in support of that. So starting with terminology. Why is this important? This is key because we all need to talk the same language, okay? When you search the literature, you need to know what search terms to use. When you talk vet to vet, specialist to specialist, veterinarian to MD, it's helpful if we're all speaking the same language. And so one of the first papers that came out from the Veterinary Epilepsy Task Force was this consensus on definition, classification, terminology. And it has its pros and cons. And so I'm going to give you my bias as to this report. I'd like to point out these are proposals. There's no sort of ratification process, and it is up to individuals to decide whether they will adopt these suggestions or not, okay? But certainly it opens up the discussion and at least gets us all onto the same playing field when we refer to this. So, key term here, semiology. This is a word that describes the physical manifestation of a seizure. Okay, the type of twitches and tics and mentation, that what you can see in front of you is the semiology. And their proposal is that the semiology should define the seizure and the epilepsy. Okay, so if it has a motor component, and we call it myoclonic, or clonic, or tonic, that is, for them, the definition, what they propose, of the type of seizure that you're seeing. So you all will have used that phrase, generalized tonic-clonic seizure. You are, in fact, following their suggestion. It's something we've done all along. They're just making it concrete, okay? They define a seizure as a sudden, short, transient event, which isn't necessarily an epileptic event, okay? I might have said prior to this, paroxysmal event, or a fit, or some sort of convulsion. None of those words necessarily imply that this was epileptic. And in fact, syncope could fall under that term. You're going to start to see some of my biases in terms of reading this proposal. And then they specify an epileptic seizure as one that originates from massive synchronous excessive neural activity, okay? If you think of a seizure, my best analogy for you is a large, crowded sports stadium, okay? And all the neurons in the brain are the people in the stadium, okay? And a normal sports stadium full, waiting for the team to come out, if I were to lower a microphone into the center of that stadium, you'd have a hard time picking out any one voice in that crowd, okay? And that's a normal, healthy, active brain. All the neurons doing their own little things, okay? And then the team walks onto the field and suddenly you can hear, Blue Jays! That's a seizure, folks, okay? No bias implied there. But that synchronous activity where all the neurons are saying the same thing at once, you could call that a generalized seizure. I will use that analogy excessively. So usually epileptic seizures are accompanied by transient signs, the semiology of those seizures. So there may be convulsions, there may be focal motor, so myoclonic, or massive motor, clonic activity. There can be increased tone, there can be autonomic signs like salivation, urination, defecation, and there can be behavioral features associated with it. So altered responsiveness, that kind of thing. They define reactive seizure as the natural response of a normal brain to transient functional disturbance. So this is where your intoxications that trigger seizures would come out. Okay, these aren't epileptics by this definition. These are reactive seizures. And once that stimulus goes away, then they are not epileptic. They should go back to normal. Epilepsy is defined as a brain disease and a predisposition to having these epileptic seizures. And they suggest further a criteria of more than 2 unprovoked seizures more than 24 hours apart. They classify epilepsies according to 3 etiologies. And to be perfectly honest, even though I pinned them against the wall last time I talked to this group, they weren't actually very good at explaining to me the difference between unknown and unknown. As you can see here, unknown and unknown. My understanding, if I may be wrong, and if they watch me on YouTube, they can email me and tell me truly, that the unknown under idiopathic are the ones you thought should be idiopathic, which essentially now means genetic, but you can't prove it. So breaking that down, genetic epilepsy, where you've got certain breeds that have hereditary component that has been described and published, and or the gene has been identified, those are the proven genetics, and they're a subcategory of idiopathic. And idiopathic is a term that we've used for donkey's years in describing this kind of epilepsy. These guys are still sort of normal between seizures, okay? The onset is still between 1 and 5 years of age, and you wouldn't find anything on any of your diagnostic tests, right? And I'll talk about that later as well. Suspect genetic are ones where we haven't got the breed or the gene nailed down in the literature. No one's done the hereditary study, no one's found the gene, but the breeder's like, yeah, I had one, you know, two lines, but 2 crosses back, one of those was epileptic as well, and or the owner says, yeah, actually, the breeder mentioned the aunt might have been epileptic as well, and so now you're suspecting these are genetic, okay? And then unknown is the doodle, okay? Standard poodle crossed with golden retrievers, both of which are epileptic breeds. So this probably is genetic, but you can't prove it. Does that make sense? versus the unknown category, which is truly, truly unknown. It's the small, white, fluffy dog that shouldn't be having seizures for fun. And darned if it's normal on neuro exam and blood work and the bile acids are good and all the rest is good and you send it off to the neurologist and they scanned it and the brain is good, that would be the unknown, okay? Because small, white, fluffy dogs, as we all know, don't tend to have seizures for fun, okay? And then in the middle are the structural. These are the very young, the very old, the ones growing a tumor in their head, the ones with encephalitis, the ones who were born a little funny and the brain didn't grow right, and when we scan them they've got more hydrocephalus. Those ones are in the structural category, okay? So just to update the terminology, and I did this 3 years ago and now we're doing it again. The older terms are the paler terms at the bottom of the screen. Grand mal, petit mal, those are out of use now. And the current recommended terminology is generalized epileptic seizure and focal epileptic seizure, okay? Just so that we're all speaking the same language when we try to talk to each other. So generalized epileptic seizure. This is a seizure that originates at some point within and rapidly engaging bilateral networks, both sides, both hemispheres of the brain. And the phrases we use to describe these are tonic-clonic, and so these are the seizures that start with increased tone, followed by rapid clonic maneuvers. Myoclonic, that's that tiny little tick that the dog's doing and you're wondering what's going on. Clonic means there was no tonic phase and they're just doing the whole thing. Tonic, again, just rigid. And then atonic, which are hard to distinguish from syncope. Typically with these ones, they're unconscious. All of these ones, they're unconscious. There's a significant alteration in consciousness and mentation to the point where they are typically unconscious. Okay, these are your classic seizures. You're all familiar with them. You've all seen them at some point. These are the Blue Jays walking into the stadium and the crowd going wild and yelling all at once so that you can hear it with your microphone, Blue Jays, okay? Focal epileptic seizures are ones that originate on one side of the brain, so one hemisphere. And these are a little bit harder to identify, but typically you can use the same language I just used for the generalized. So you could have a focal seizure with myoclonic twitches, and the mentation and sensorium might be otherwise undetectably normal to you, except for this continuous twitch. Okay, you might be worried there, this is a focal seizure. Otherwise, you might see altered consciousness. So the patient might be blanking out in front of you, and you can wave your hand in front of it, and it's gone for a second or two. There may also be other motor or autonomic signs. There may be salivation, specifically, I see that a lot with cats. They drool a lot during the seizures. They may not go into a generalized tonic-clonic seizure. You just see drooling and a wobble, and they space out, and then they're back, okay? That can be quite subtle. Focal epileptic seizures are recognized to evolve sometimes to become generalized, okay? So this is where that one focus spreads to networks on both sides of the brain. Why do we talk about generalized versus focal? Because in the published descriptions of the breeds and the breed-specific epilepsies, the description of the type of seizure they have is helpful in determining if they're having that breed-specific epilepsy. So for example, Lagotto Romagnolos, not that they're a hugely common breed in this part of the world, may be having predominantly focal with secondary generalization, okay? And they start with a typical onset, a very stereotypical onset, as opposed to the generalized that could start first on the left side of the body today, next day on the right side. Does that make sense? Okay. So, coming back to the consensus report on terminology, there are some weaknesses in this report. They don't talk about absence seizures. Absence seizures are a fairly recently recognized problem in veterinary medicine. So already this consensus report coming out in 2015 is a little bit behind the ball on this one. Absence seizures are just like that, where the human or the patient or the dog in this case, or the cat, just pauses for a moment, blanks out and comes back. And one of the reasons they don't focus on absence seizures, and one of the reasons we've gotten away from saying partial or complex, simple or complex partial seizures or simple or complex focal seizures, is because it's really hard for us to look at a dog and determine how the mentation is different. If they're unconscious, we're all pretty good about figuring that out, okay? But spaced out, that's a challenge, okay? And that's one of the reasons they shy away from using this category in their classification and terminology. I'm not so sure that that's a really good idea, because I think this is an underreported, and this is my personal opinion coming through, I think this is an underreported and under-recognized area of seizure and of epilepsy in dogs and cats. And one of the reasons I say that is highlighted at the bottom of the screen. The research I do is in electroencephalography, EEG. I record the brain activity of dogs and cats, and what I do is I do it while they're awake. Okay. Classically, historically, we've heavily sedated or knocked these animals out to record their brain waves. And for the most part, we get the brain waves of heavily sedated or knocked out animals, which is not helpful if they're only showing the seizure type when they're awake. And what do we do to treat a status or badly seizuring animal? We knock them out. That's our treatment. So if we're knocking them out appropriately, we're not going to see a lot of the abnormal brain activity because we've done it right. And so I think that with increased uptake of EEG, with making it easier for people to use, people like you guys, making it into a Holter monitor for your typical GP to strap onto a patient, send home for the weekend, and then ship off for results, I think we're going to revolutionize our understanding of this type of epilepsy. Does that make sense? So then moving from that, generalized versus focal. In the human epilepsy world, that definition is not based on the semiology. That definition is not based on the outward appearance of the seizure, of the fit that they're having. In the human epilepsy world, it's entirely based on the EEG characteristics. And that's not practical right now. So I totally understand why they've made the recommendations they've made. But my fear is that as we EEG more and more of these cases, we're going to have to redefine everything again. Because we're going to find out that, those absence seizures, they're generalized. Okay. Or those myoclonic twitches that you have been defining as focal, well, they're also generalized. Or that generalized seizure you thought was happening is consistently starting in the right thalamus of that kind of dog. Okay, that would significantly change our approach and perhaps our treatment and our stratification of these patients when we're trying to treat them. Does that make sense? In the human world, they use EEG to define electroclinical syndromes, and these electroclinical syndromes have known prognosis, known treatment, contraindicated treatments. There are certain electroclinical syndromes that phenobarbital makes worse. Okay, and we're not anywhere near that in veterinary medicine. So again, I think this is a good start, but we're slowly going to have to change this again. And then finally, they don't touch on one thing at all called non-convulsive status epilepticus. And that is when there is no outward semiology to the status epilepticus except for loss of consciousness. Okay, so you've got a limp dog presented. Yeah, he was having a seizure a while ago, and now he's just limp and unconscious. Okay, did he pass out? Or is he still having seizures on the inside? His brain is cooking, but there's no more motor activity because we burned out those bits. Okay, and that to me is a significant issue as well. And diagnosis will be helped by doing things like EEG, just the same way the ECG revolutionized our approach to the heart. EEG will revolutionize our approach to the brain in cases like that. And so there are no recommendations on non-convulsive status epilepticus at the moment. And so I'm going to end again. I think EEG is going to change things. I think it is changing things. And I can expect to be doing this update again in another 3 years and hopefully update our recommendations based on what we found. So moving on, breeds. Breed-specific epilepsies. There was an excellent summary of our current understanding of idiopathic epilepsy of genetic or suspected genetic origin in purebred dogs. And again, this shouldn't be a huge change to what you know. It just makes things more concrete. The onset tends to be, and I've put the whole chart in your notes. It wouldn't fit on the slide. But for every breed that we have studied and is a known genetic or presumed genetic epileptic, this chart very helpfully tells you the age at seizure onset. For size purposes, I didn't quite get all the references into this pages in your notes for you. But if you went to the open source journal article, those references are there. And you will note that the youngest age of onset is about 6 to 12 months. Okay, so they typically start about 6 to 1 year of age, and the oldest is probably about 5 years, if you flip through that chart. So a very helpful, handy chart because it helps you, frontline, to determine whether that Aussie Shepherd in front of you that presents age 2.5 years with generalized tonic-clonic seizures is probably a genetic epileptic, especially if it's normal on neurologic exam between seizures. The other helpful thing I found in this paper is this description, like I said, of the seizure type. So again, understanding that they're describing seizure type based on the outward manifestation. They describe the types of seizures that you can expect to see with these breeds and how likely they are to have that type of seizure. And then even cooler, the remission rate. We'll discuss that again later. Remission, epilepsy remission. It's a concept that hasn't been much discussed until now. And so I want to table that for your consideration as well. Weaknesses in the data that this task force collected is that most of these studies were performed outside North America. There's only 2 American studies in that whole list. So that's a prod in my backside to get moving and to our colleagues on the North American continent to better identify what's going on in North America, because these are genetic or suspected genetic, but we don't know how well the lines are mixing across the ditch, okay? And so take those statistics with that grain of salt when you look at that chart, okay? These are European dog lines for the most part. The other problem is that we don't have yet, and I guess it's not the problem of the report, but it's highlighted by what's in the report, that there aren't really any good breed-specific treatment recommendations yet. Okay, I think that's coming as we push our understanding of these syndromes. We'll be able to say, oh, don't use pheno in those, use levetiracetam. That breed really responds a lot better to that. And in my last update, I mentioned that, for example, Border Collies, the ABCB1 or MDR1 mutation doesn't seem to affect their drug responsiveness, that kind of thing. So we're gradually understanding more what the genetics, how those genetics are impacting the type of epilepsy and their treatment, but we're not there yet. And then finally, it also highlights that we're not there yet with the genetic tests, okay? You can't help your breeder clients yet, at least not all of them, because I think there's only 2 tests available at the moment, one for Legatos, and the other is coming down the pipe for Belgian Tervuurens and Berbels, which are a subset of German Shepherd dog style dogs. And again, this is the European crew, so we don't know how prevalent this mutation is in North America. Diagnostics. So I always enjoy this slide. It's one of my favorites. Okay, we've all seen it. Things mistaken for seizures. My list used to be longer, but these are the ones they called out specifically in the diagnostic consensus proposal. Syncope. I think that's everyone's nightmare, distinguishing the syncopal patient from the seizure patient, especially that atonic seizure I was talking about. Well, here is where the Holter comes in, and hopefully in the future where the EEG might come in, especially being able to do both, right? Is that sudden atonic collapse to the ground due to the heart stopping or to the brain getting a little excited? I have recorded a few, and we're hoping to record more, especially in cats, because sometimes their heart-related syncope is notoriously hard to catch with ECG as well. And Holter monitors for cats, a little bit challenging still. Narcolepsy, cataplexy. Okay, I'll remind you, narcolepsy is the tendency to fall asleep suddenly and inappropriately. This is often lumped together with cataplexy, which is atonic drop attack from excitement. And there's some cool videos on the internet, if you were to look them up, of excited dogs suddenly collapsing in front of the dish. But that would be your classic cataplexy, where the dog is so food motivated, so excited by, oh my God, dinner. It's a bit sad. Neuromuscular weakness. Okay, that's another classic one, especially the myasthenics that are generalized but not insidious. They weaken very rapidly, so they walk and then they drop as well. Big one, paroxysmal behavior changes, classically your compulsive disorder. Okay, some of the ones, the big challenges facing us right now are those staring attacks that bull terriers and American staffies and those other big muscle type dogs do, where they'll walk under something that brushes their back and they sort of freeze and move really slowly. Are those behavioral? Are those some sort of compulsive disorder? They just like that slow tickle down their spine? Or is it some type of seizure? That's a classic example. Another one, fly biting, okay, where the dog is chasing or snapping at something in the air around it, and you could swear it's following something that's just not there. One recent paper came out, suggested that this might be due to GI upset of some sort, and a case series showed foreign bodies or inflammatory bowel disease on biopsy for dogs that were doing this fly biting, flank licking episodes. However, some of them are not. And so what's going on there? Are those seizures, or are we mistaking them for seizures? Vestibular attacks, okay? Not all vestibular attacks are permanent. We certainly do see transient ones. I'm sure you've all had that case. Well, he was staggering around, but his eyes were moving sideways. And within an hour or two, he's back to normal again. What was that? Could that have been a transient stroke? Was that a seizure? That's always a big question. Typically with seizures, you don't see nystagmus or a head tilt. However, that's, I was going to say very, very, very rarely in humans you can see nystagmus associated with seizures. Has it been reported in dogs yet? No. So another thing up in the air there. And then they also report idiopathic head tremor. And I'm sure you've all seen those. The big-headed dogs, the labs, the Dobermans, the bulldogs, the boxers, and they'll have the yes or the no or the maybe head tremor that comes and goes, waxes and wanes over the lifetime of the dog, seems to get worse with stress. The owner says, oh yeah, I can interrupt it with a cookie. Well, in this consensus proposal, they are listing that as something that could be mistaken for seizures. Again, I've recorded a couple of them that might suggest otherwise. So I think these are, this is a question that's up in the air. Yes?
We've had some debate. We've had a couple of cats where they look like they're trying to spit their tongue out. Like they're like...
Cats.
Yeah, like very focused and like not really responsive and doing its mouth movement, and we weren't really sure if that is a seizure or is it a sign of reflux or something. Like, what do you think about that?
Absolutely. Let me repeat that question. From the audience here, we have a member who's describing cats that are seen to almost be trying to spit their tongue out, like trying to expel their tongue or some bad taste on their tongue. And is that a seizure or not? And I would argue that Honestly, with this, we wouldn't be able to say unless we recorded them. I have one cat that I did record that, along with the drooling, was doing that behavior. And it proved to be in having generalized seizures that over time actually worsened to become status. And unfortunately did not survive. And on postmortem was shown to have hippocampal necrosis. That's an N of 1. Are they all that way? I don't know. There could equally be some that are just having a sensory seizure that, oh, that tastes really, you know, I smell burnt toast. Yeah, I taste burnt toast. That's a really odd flavor. Or it could be some GI upset, esophagitis. Like, I think there are other things to consider as well. So I can't give you a straight answer on that, but I would suggest that recording the brain might be the next step to better understand that. Okay. So, a diagnostic approach to epilepsy in dogs. The recommendations here, again, should not be a surprise to most of you. Very, very simply, the first question is the animal having seizures? And so that cat question was actually quite appropriate because, as I come to, it can be very, very difficult to determine whether the animal's having seizures. And then, once you've determined that it is an epileptic seizure, put it into the category of reactive seizures. Those are the ones where it's a normal animal and something's triggering it, and if you were to take away the trigger, the seizures would go away. Or structural or idiopathic epilepsy, and then my favorite category, unknown. So, epileptic seizures or not, the recommendation is to get a good description of the phases of the seizure. So the pre-ictal period, what's leading up to the seizure itself, the ictal period, and the post-ictal behavior. In this day and age, you will have found, I'm sure, that most of your clients can provide you with a video. Cell phones are everywhere. I also included in your handout the standardized questionnaire that the task force is recommending. Along the lines of, if we collect the same data thoroughly from as many patients as possible, then it will further our understanding of what's going on. And so the task force makes this a global appeal to everyone to jump in and help. Does that make sense? And so if you start collecting that data, at some point your epilepsy researcher might give you a phone call and say, do you have any data you might be willing to share? And then we can move forward with North American studies. So that standardized questionnaire, the digital form, again, is attached to the open access journal article. So very easy for you to access in digital form, okay, as a docx file. The big question is consciousness. Is the animal conscious or not? And like I said, I think we could all very easily agree on an unconscious animal. The question is that bit between fully conscious and unconscious, and the shades of gray in between. And I will come back to that as well. And key questions as well for the owner are interictal mentation and personality. Are there any changes there? You want to look at duration, frequency, time of day. Seizures are most common when drowsy or sleeping. So if you think back to that stadium analogy I gave you, okay, if generalized seizures are the whole crowd yelling Blue Jays, and focal seizures are the other team coming on and their crew now shouting, oh, I don't know, what's another, thank you, Yankees. So now you've got Yankees from this side of the crowd. That's a focal seizure. The rest of the Blue Jays crowd is not impressed, okay? And then as far as seizures most common when drowsy, if you think of that seizure focus of the drunken boys in the group down at the bottom seats, or usually the upper seats, and they're trying to get the big cheer going and the crowd's busy watching the game, but suddenly there's a lull, okay? The energy level of the crowd drops and they catch on. And suddenly the chant is going and the whole crowd is going and your microphone in the center of the stadium picks up that word, okay? That's what happens when the brain is sleepy, drowsy, relaxed. That's how a seizure focus can take over and get the whole crowd saying the same word. Make sense? Similar analogy. Back to my personal bias, which I'm injecting through this entire talk, EEG. is an absolute necessity to determine whether a seizure has occurred. And in fact, the task force agrees. EEG is an absolute necessity. They just acknowledge, as I do, that it's a challenge to do, and not everybody can afford to do it at the moment. But I would interject that technology is getting cheaper, and it's going to get easier, and I'm sure we will be doing it soon, and then we'll have another update. So, I'm going to mention this talk at this point. A really cool study that came out last summer. They took 100 videos on YouTube of paroxysmal events in dogs and cats. They took 10 DIPs, people like me, and 5 GPs, and sat them down and made them go through all 100 videos. First question, epileptic seizure, yes or no? And then if not, what is it? So, agreement, kappa, K. High agreement is 1. 0.5 is 50-50 pretty much. Okay, low agreement between specialists, between GPs, between specialists and GPs. Low agreement, looking at the event in front of you. Forget description, okay? Forget the history. You've got a video of the event in front of you, and we still can't agree on what's going on. Back to what I was saying, EEG is an absolute necessity, okay? They could agree on when they were unconscious, flat out. Okay, yes, we pretty much agreed on that. But anything else, no agreement, poor agreement, okay? Poor agreement. So, I'm just gonna leave you to think about that. Right, so as I said, none of this should be a huge surprise for you. It just rigorously sets it out. When you're diagnosing these, you've done your history, you do your physical, you do your neuro exam. I strongly recommend you do the whole exam because we don't take shortcuts, do we? And then I'm going to ask you, just for a little moment here, think about what 4 tests on your routine neurologic exam are specific to the thalamocortex, where seizures originate. Could you list them? Regretting that cookie? Okay, there you go. Mentation, menace response, nasal septum response, and postural reactions. Okay, mentation, that's observation, and the other 3 we actually test for. Right? Those are the 4 that include the thalamocortex in the pathway for those tests. Right, if you don't find anything, then you've probably got genetic idiopathic epilepsy if they're the right age, right breed, right style of seizure. Or, bad luck, you might have early neoplasia. And it's just not big enough yet to cause deficits on menace response, or nasal septum response, or postural reactions. Those sneaky prefrontal, frontal cortex, olfactory bulb tumors, those are the ones that can grow quite big before they actually show up as deficits on your neuro exam. Just keep that in mind, okay? If there are deficits, well, then you have to wonder, are these postictal? In which case they'll go away within about 7 days. Okay, if they persist beyond 7 days, not postictal anymore. Drugs, okay? Not just the drugs you prescribed, but potentially drugs they got hold of. And not just recreational drugs at home, but prescription drugs at home could also trigger these. And structural epilepsy. So not the early neoplasia, but the solid potato in the head. Okay? Those ones will give you deficits. Your minimum database, again, no huge surprise for you. CBC, Chem, UA. And then another little quiz for you to think about. The 5 tests of liver function on a routine biochem panel. Nothing special, just a routine biochem panel. Not going to call you out. It's a bit late in the evening. But think about that for a moment. Some of those are easier than others. Ready? Yeah? Did you get them? Okay, glucose, that's what the liver does. Albumin, also what the liver does. BUN, conversion. Bilirubins, what the liver does. Cholesterol, package up that meal. Okay? So then we move on to your discretionary database. These are the tests that you do if you think this isn't quite your typical genetic idiopathic epileptic. Thyroid panel. Full thyroid panel in a dog, please. Hypothyroidism in dogs predisposes them to strokes. And strokes like to occur in the cerebellum or the thalamus. And if it's in the thalamus, they might be having seizures. Ditto for the cortex. Blood pressure. Just a reminder for that you want to note your machine cuff, limb, and recumbency, and you want to do it 3 times. 3 separate occasions to confirm your hypertension. Ocular exam, a fundic exam. Often what's going on in the brain can show up in the eye. It's the one nerve you can look at without doing anything really fancy. Ammonia, pre- and postprandial bile acids, okay, for your hepatic encephalopathies. Fructosamine and glucose curve. Oh, glucose-insulin ratio for that possible insulinoma. Toxicology screens, some more reliable than others, especially when the owner can't or won't say, or the owner's children can't or won't say. Titers, PCR for infectious diseases, genetic testing for the few genetic known deficits, mutations that are known. And of course, the MET check, thoracic RADS, abdominal ultrasound. And then we get to the advanced database. And the recommendation here is MRI over CT. Okay, MRI gives us what we could see in the brain with our own 2 eyes as if we were peeling it apart. Much better than CT. And so the recommendation is MRI. This is usually accompanied by a spinal tap so that we can see microscopically what's going on around the brain. And then for the future, there may be biopsies that we could do, but that's certainly not something I can sell very easily right now. I keep saying brain biopsy, people keep saying no. I have to figure out a different way to market that. But so I leave a question mark with that. The routine is definitely imaging and CSF. And the question is when? When do we do that MRI? And so between the diagnostic consensus and, I will show you shortly, the MRI consensus, there's 2 statements on that, as to when to do MRI and what to do specifically. So if the epileptic seizure onset, if that age of onset is less than 6 months of age or older than 6 years, you really should be recommending an MRI. If you've got that abnormal interictal neuroexam, like I mentioned earlier, okay, those are all good reasons to consider an MRI. If they're presenting in status epilepticus or cluster seizures, first time for everything, then you want to do your MRI. And if you thought this was a genetic epileptic, but darned if your treatment isn't working, okay, time to consider that MRI. They have, in that MRI recommendation manuscript, they have recommendations for low and high field MRI. So when we say low or high field, we're talking about the strength of the magnet, and that's measured in Tesla, okay? Here at OBC, we have a 1.5 Tesla magnet, and other magnets out there range from 0.2, 0.5, the smaller low field MRIs, up to the crazy high 3, 4 Tesla, 7 Tesla, well, the 7s at least are research related. In the human field, hospitals have been working their way up the Tesla gradient. Started with 1s, chucked them out, got 1.5s. Now they're chucking those out and getting 3s as standard in human medicine. And the reason is the higher field MRI gives you better resolution of the tissue you're looking at. Okay? And this task force points out that high field MRI may be required for these 3 conditions. So specific cortical dysplasias are not going to be picked up on a low field MRI. When I say cortical dysplasia, I'm saying a brain that's too wrinkly, a brain that isn't wrinkly enough, or a brain that has islands of neurons where it shouldn't be. Okay, so islands of neurons within the white matter, for example. Infectious diseases. Distemper and rabies, for example, have often very subtle signs that a low field MRI is not going to pick up. A low field would come back as normal. And for metabolic conditions, examples here are hepatic encephalopathy or thiamine deficiency. Again, there may be subtleties that a low field MRI would call normal, but a higher field MRI would pick up. So keep those in mind when you're recommending what type of imaging to pursue to your owners. So I'm going to take all that info I just gave you about the types of database, your minimum, your discretionary, and your advanced, and we're going to put them into tiers of confidence for that idiopathic genetic epileptic diagnosis. Okay? So tier 1 is your normal minimum and add-ons. Normal physical, normal neuro, normal CBC Chem UA, and any other discretionaries you chose to do were all normal. That's your tier 1 confidence, lowest level of confidence. Okay? You are more confident if you've also done tier 1 plus you've got normal bile acids and the advanced database, normal MRI and normal CSF. That's a tier 2, much more confident. Tier 3 is all of that plus EEG. Okay? Speaks to my heart. Good. So, one of the other papers the task force put out is on systematic sampling and processing of brains from these epileptic dogs and cats. And I mention this to you because not all of your patients will necessarily go for the full PM. But if you were so inclined, you might consider taking out a brain here or there and submitting it for research, for answers, that kind of thing. And this paper, again, open access, easily accessible for all of you, has a lovely how-to guide on collecting the important bits of the brain to submit, should you and your owner be so inclined. Very, very helpful, especially for somebody who doesn't take brains out that often in this scenario. I like the pictures and should be fairly easy to follow along with. I will put a plug in here, okay? Any former OVC patient can come back at this point. There's the loophole they haven't closed yet. Can come back at this point for a free PM. Oh. Okay, you just have to arrange to get it to our front door. Well, don't bring it into the lobby, but get it to our front door. Let the front desk know that you'd like to admit a DOA, basically, for the PM. Okay? Take that home, tell your colleagues, remind your colleagues, because underneath all of us is somebody who'd like to know what happened. Yes.
Can it be for any OVC patient?
Any previous, well, neuro will helpfully facilitate any neuro cases, but yes, any OVC patient across the board. We would all be extremely grateful. It's helpful if you call a service that was most interested ahead of time and let them know such and such is coming back, DOA for post, okay? But that is, I mean, it's up there with a monetary donation, allowing us to have a look after their pet has passed on and learn from that pet. That pet is immortalized. And so I cannot speak more gratefully for every family who has chosen to let us have a look afterwards. That is the biggest gift they can give. On that note, treatment. So, lucky us, there were 2 consensus statements on this topic last year. Not only did the international task force put one out, but the ACVIM also published, and that's also open access. So in this next section of the talk, I've distilled the commonalities of the 2 consensus proposals for your edification and put some diagrams into your notes as well. So, when to start anti-epileptic drugs? Well, if it's structural epilepsy, yes, absolutely. Okay, they're growing a potato in there, yes, it's time to do that. if there's prior brain pathology. So, you know that accident with the baseball bat and the 5-year-old kid a few years back and now it's having seizures? Yeah, that probably needs anti-epileptic drugs as well. Status epilepticus, by definition, anything longer than 5 minutes continuously, start drugs. More than 3 seizures in 24 hours, start drugs. Or 3 or more is probably the better way to say that. 3 or more in 24 hours. 2 or more in 6 months, start drugs. Prolonged, severe, or unusual postictal periods. One case we had, the dog was extremely aggressive postictally for about 3 hours, bit everybody in sight. That would be a good situation to treat, okay? Then the question, of course, is which anti-epileptic drug and when? And once again, I'm not going to change your world dramatically with these recommendations. I'm just giving you the evidence upon which you're making them. Okay? So here, for the level and grade of evidence, level 1 evidence is the best evidence there is. That is a randomized, placebo-controlled, blinded trial. Level 4 is expert opinion. Me. Okay? But that gives you that range there. The grade of recommendation, A is the strongest recommendation. D is, yeah, don't even bother. Okay? So hopefully this chart is helpful from that perspective. Obviously, the best evidence we have is for phenobarbital, for bromide, and for a European drug called imipitoin. Many of you may not have heard of that. I don't believe it is being authorized by Health Canada yet. I don't think it's active in the States yet either. My understanding is that Boehringer Ingelheim is looking for those permissions. However, it's going to come, and so you need to be aware of its existence. You might be surprised to see the level of evidence for levetiracetam. We use it a lot. It's only a level 4, which is expert opinion. Several studies were done on this drug, and they didn't reach significance. They were underpowered, under-end, and so we're going on gut instinct, expert gut instinct here, which is probably about as good as anyone's gut instinct. We don't have that strength of evidence. And then zonisamide is gaining ground. It is approved in the States, but not here in North America. It's probably the next best. There are more studies on it underway south of the border. I would point out, though, at this point that phenobarb is the only one that's licensed here in Canada for use in dogs and cats. Dogs, our lovely sponsors. So, when to monitor serum drug levels? Again, this is common sense. This is stuff you're already doing, but it's finally listed out for you. At steady state, after starting a treatment or changing the treatment. One of the charts I've shown to you, I think it's on my next slide, lists helpfully when those times might be. Uncontrolled seizures, despite an apparently adequate dose. Signs of dose-related toxicity. And to check for pharmacokinetic drift, or check for compliance. Okay, 1 for you, 2 for me. So here you go. This chart, also from this paper, yes, from this paper, lists drug monitoring and ideal dosages. And because they use units that we don't routinely use here, I've added the Canadian ones at the bottom of this slide for you. So for phenobarb, we aim for 100 to 120. You'll notice the lab range is this wide. And we actually aim for something close to the middle of that. Below 100, I just don't find is all that effective, at least for the cases I see, which are the cases which are not working for you. And above 120, they start to stagger. And again, there are exceptions for every rule. I ran one case at 195 for about 5 years, but it needed it. And it was not staggering, so it was good. And bromide. We actually tend to run it above the lab ranges here. We run at 20 to 25. I find as a monotherapy under 20 isn't very effective, and over 25 they're staggering again. So those are our sort of functional rules of thumb that we use here on the neurology service. Risks of treatment. Again, they categorize them into 4 types. One is your predictable type, dose-related. 2 is your idiosyncratic. 3 is your cumulative, so prolonged treatment, and it's piling up. And then 4 is your delayed, so carcinogenic or teratogenic. And fortunately, if you look at this chart, none of the drugs we use are category 4. Okay, and you knew that. All of them have category 1 though. Okay, these are predictable dose-related adverse effects. Too high, they start to stagger or they go off their food. Too low, well, that's a different problem. Category 2, those are your, just to remind you, idiosyncratics. And we certainly do see those with phenobromide and zonisamide, but imipitoin and levetiracetam are clean, typically. And then very few in the category 3, which is the cumulative. And like I said, none in the carcinogenic or teratogenic category. Then we get to the interesting part of the evening. The non-pharmacologic treatments. Okay, and there are several reviews out on this in the last few years, culminating in the 2015 ACVIM consensus statement. Vagal nerve stimulation. You may have heard of this. This is where they implant an electrode around the vagus and a sub-Q little box, kind of like a pacemaker, same size. And it stimulates the brain by firing impulses up the vagus into the brain itself. It has shown to be somewhat effective in humans, and a number of studies have been done in dogs, small groups of dogs, none of which have achieved strong power and good significance. Okay, so small groups of dogs, 30% improved at the end of the 8-week period, that kind of thing. Nothing big, nothing strong. That's why I've put no question mark. There are more studies underway right now that have shown that with vagal nerve stimulation, dog brain chemistry changes. Okay, not just brain chemistry, but neurotransmitter chemistry, that sort of thing. Brain metabolism. So it does have an effect, but not to the same degree that we see in humans with vagal nerve stimulation. And I know, not necessarily through any of you here today, but through some of your colleagues out there, we have fielded inquiries about vagal nerve stimulation. And my current reply to those clients of yours is that we don't have strong enough evidence yet to really mitigate the cost of buying one of these multi-$1,000 implants and putting it in your dog. I just don't see the evidence as being strong enough yet. And it may be that it just doesn't work for dogs the way that it works for humans, okay? So that's my message on that one. Diet, yes. Question, do we think in humans there is a placebo effect? Answer, yes. However, once you've implanted it, you can remotely turn them on and off, which means that the human or the owner doesn't know whether the thing is firing or not. Okay, so there are ways around it, but you've got to put a multi-$1,000 implant in first. That's what the studies are doing. We just haven't managed to do it in a large enough number of dogs yet to really make a difference. Does that make sense? To really answer this yes or no? Good question. Diet. This is another question that I'm sure you all field because you passed the question on to me. And I don't mind answering it, but I'm going to answer it again here. The ketogenic diet is successful in human children. Okay? Humans are easy to create a state of ketosis in. Dogs are not. And in dogs, even with a measurable state of ketosis, we aren't seeing an effect of the diet on the seizures. Does that make sense? The research has been done and it really isn't effective. Ditto for omega-3 fatty acid supplementation. Sufficient research has been done that it really isn't any point at this point supplementing omega-3s for the purpose of reducing seizures. Fair enough? Medium chain triglycerides, though. The jury is leaning towards yes question mark there. These are diets that are obviously based around a medium chain triglyceride, and the preponderance of evidence is that this is able to decrease seizure frequency by about 50%. Okay, so we're heading in that direction. Not enough to say a strong, resounding exclamation mark yes, but we're heading in that direction. So watch for that. Acupuncture. I feel a lot of questions about that. The preponderance of evidence in humans, and you can go to the Cochrane Review database, is that it does not work for epilepsy in any way. And the few studies that have been done in dogs also show that it is not helpful in dogs. So I tell people don't waste your money. There are other neurologists who will say, well, if you want to waste your money, go ahead. I'll leave that to you. Homeopathy. Also a resounding clear no. Don't waste your money. Not effective, sufficient data, sufficient evidence at this point. Don't bother. Okay? So the one thing I found very interesting from these task force proposals is that they held us up to the human standard of treatment here, which is seizure freedom, freedom from all seizures. You guys see a caseload that I don't. You send me the ones that aren't achieving seizure freedom. So I don't see seizure freedom that often, and I would be curious to know how often you do. I don't think that answer is very clear in the veterinary literature at this point as to how often we actually achieve that goal. Their definition of seizure-free is more than 3 times the longest pre-treatment gap and an interval of at least 3 months. Okay, I have maybe 1 or 2 patients I've graduated to that wonderful space and sent back to go on to do other wonderful things. However, realistically, the secondary goal is what they could term partial therapeutic success. Okay, and so this is prevention or management of cluster seizures or status. This is a relevant reduction of seizure frequency considering pre-treatment seizure frequency. And I like how they diplomatically say that, because really when they do the research into efficacy of seizure treatments, they're looking for a 50% reduction. Okay, and that little piece of client education is huge. For the patient coming in with daily seizures, 50% reduction, which is considered success, is every other day. Okay, weekly seizures is every other week. It's all relative. And so for those ones, maybe seizure freedom really isn't a very viable goal. And then also a reduction in seizure severity. That which was 3 minutes is now 30 seconds. Awesome. That which was generalized tonic-clonic is now reduced to a couple of twitches of the head. Wonderful. Okay, I'll take those. And then further along this algorithm, we can look at whether we need to add another anti-epileptic drug or continue managing this long-term success. Which brings us to the outcomes. They recommend, and it's something I confess until they pointed it out, I was a little bit sloppy with. They recommend stating this patient is drug resistant to X anti-epileptic drug. Okay, and ditto for the intolerance. They recommend explicitly stating it in the record, this dog is intolerant to phenobarbital due to bone marrow suppression. Done. Okay, that way the next vet along the line doesn't have to go searching back through 40 pages to figure out why did we stop the phenobarb. Okay, ditto, why did we add the 3rd drug? Well, this dog was drug resistant to phenobarb, to bromide, and now we've added levetiracetam. By explicitly stating that, And again, it's just a little thing, but I've been a bit sloppy with it. I wouldn't be surprised if others are as well, that being that explicit helps the next one along the line. It also helps the owner. My dog is resistant to. My dog cannot tolerate this. And those are good to know. Another thing, remission rates are reported in dogs 15 to 30%. In other words, they achieve that seizure freedom I was talking about and can be weaned off their drugs eventually. How cool is that? I don't get to see that many of them, but still, the least likely to go into remission are, in order of least likelihood, Border Collie, German Shepherd Dog, and American Staffordshire. And the recommendation is, after 1 to 2 years seizure-free, you can consider weaning them. And that would be your remission out the door. Cool. Another fun question we've all fielded, I'm sure. There's this paper out there. The title is across the top of the screen. Cannabidiol exhibits anticonvulsant effects in animal models of temporal lobe and partial seizures. Awesome. I've already had clients coming saying, can we have the cannabidiol, please? Well, if you read the paper, this is a study in rats in whom the epilepsy was created with drugs. And then they gave cannabidiol, and it seemed to have an effect. So, I have no idea how cannabidiol works in dogs. We have no idea what the harm is. I mean, you've all seen the pot dog, right? And they're relatively harmless. But who knows long-term effects of cumulative dosing. Certainly in humans, there are questions about cumulative dosing of certain types of marijuana. Unknown dosage. I don't know what an effective dose would be. I don't know how to scale from rat to dog. And unknown half-life pharmacokinetics. How often are you going to give it? Every time it has a seizure? Daily? Multiple times a day? No idea. Okay, so this is my standard answer to those who inquire about this topic. It's definitely a hot topic, but at this point, I personally would not feel comfortable prescribing it. Does that make sense? And that's why. And that's why. Rats. This study was done in rats. Not helpful at all. So moving forward, this is the future. This article is in press. It hasn't even been published yet. I think it just came out in e-form. And this is what would potentially bring us up level with the human field in terms of the cutting edge, literally, of epilepsy treatment. And that would be removing the part of the brain that is triggering the seizures. So backing up one step from that, the first question is identifying the part of the brain that is causing the seizures. And in order to do that, back to my favorite topic, EEG. Okay, we need to put electrodes on the brain and figure out under which electrode, and this is a diagram here of a suggested electrode placement protocol, and figuring out which electrode is closest to the part of the brain that's causing the seizures. And then in human children, what they would do next is peel back the muscle, take off the skull, and put a grid of electrodes directly on the cortex, and place some deeper electrodes in. And that child would then live in the epilepsy unit for a few days, up to a week, while they record the brain as the child goes through its process. And then having identified the really, really smallest part of the brain that is needed to be removed to stop the seizures, they would then do that. And it's actually quite successful in pediatric epileptology. We're just not there yet, okay? This paper, not open access, I apologize for that. I don't believe this one is open access. Discusses what we would need to do to get there, okay? So first up is agreeing on where to put the electrodes. Second, we need to do some really fancy imaging studies, okay? And for that, we would need, remember how I talked about the strength of the MRI? We would need minimum 1.5 Tesla. Was that just me or did So minimum 1.5 Tesla to do cool studies like this. So our machine can do this, not with quite as fancy a coloration. Ours comes out black and white. But basically, this is your typical brain sequence. And then these are special sequences that allow us to look for where it is bright and on this sequence and dark on this sequence indicates that that part of the brain has cellular or cytotoxic edema. Okay, so you're with some really fancy software and hardware, we can get some very specific understanding of the metabolism and damage to neurons in the brain. And then going further from that, fancy things like PET scans and functional magnetic resonance imaging, which is done in awake or lightly sedated individuals, looking at brain function in real time as the brain is processing. So really fancy stuff that would be needed to be done before we can do something like epilepsy surgery. But a number of articles in this field in the last couple of years have said that this is a foreseeable future. Okay, it's coming. So, giving you some take-home messages here. What I can say, what's so exciting that's happened in the last 6 months is that we are potentially starting to speak the same language. Us as veterinarians, communicating with MDs who look at this problem as well. And if we all speak the same language, we can all move forward together, okay? The big question facing us is it a seizure? And my solution I'm proposing to that is EEG, and I'm not alone in saying that. So take home here is watch this space. I think in the next few years, an EEG revolution will occur, and we will be having this discussion again, 2019, and I'll say, so with the new EEG protocols, you can right away and get this package, put it on the dog, send it in, get it analyzed, get some answers, away we go, okay? Genetic testing, also coming down the line, okay? We found 2 genes so far, and I think that process, if you look at when these genes were found and the time between finding them and the next one coming down the line, that time is getting shorter and shorter. So again, watch this space. There will be more and more genetic tests for you to run on your patients to figure out what's going on. And then as the evidence gets stronger, we can start to provide you with treatment algorithms, some of which are hinted at in these consensus proposals and that I've copied into the handouts you have, okay? And if we are able to treat as cohorts, we can look at outcomes as cohorts. Does that make sense? Like, I think we are all part of this wave in the progress that we are making with canine epilepsy. So I'd like to thank you very, very much for listening to that. Hopefully for taking some of it away, hopefully for participating in some of this, because this is going to be a grassroots level change. And I want to thank anybody out there on Twitter and the internets who might be participating as well. And I want to thank our sponsors, Vetoquinol. They have EpiPen, the only licensed phenobarbital in Canada. And I would like to take any questions at this point. Cases on the topic I've just discussed, anything neurological, I'm open. Yes?
What's your stance on, say, an old pug, 12 years old, suddenly starts having numerous seizures, use of steroids?
The question is, old pug, 12 years old, suddenly starting to have a lot of seizures, use of steroids. Okay, so first up, we have a breed that is not classically known for its genetic epilepsy. Second up, it's ancient. I presume at this point it has no neurological deficits on its interictal neurologic exam.
It hasn't ever gotten back to normal since the first seizure.
Hasn't ever gotten back to normal since the first seizure. Confused. Well, mentation is one of the 4 tests for the thalamocortex. And so at this point, we are very, very strongly pointing towards structural epilepsy. There is a problem in this dog's head. Now, if things aren't progressing, so if the neurologic exam, although not normal, is static between seizures as time goes on, the pug may well have had a stroke. It may not be growing a tumor in there. Okay, and strokes do happen. If it was a tumor, it would snowball. It would go from just abnormal mentation to abnormal mentation and blind in one eye to abnormal mentation, blind in one eye and knuckling on that side, to circling in the opposite direction. So you'd see over time this gradual progressive collection of neurologic deficits on your exam. Yes? Even with multiple seizures, could still be a stroke, yes, because if the stroke has damaged those neurons, they are now potentially a focus for the seizure onset. So he's learned a new trick. That's why we treat them, because we want them not to learn this new trick, and at least not to get better at it. They've already learned it. But we don't want them practicing, okay? The more you practice, the worse it gets. Yeah. Does that answer your question? So I would be seriously concerned. But following from that, strokes, they happen more commonly than we originally taught. And we're finding this out because the more imaging we do, the more we can, I had that image up showing how we could determine that in fact a stroke had occurred. We're seeing that more and more. And I mean, this is a good news outcome except for the seizure part, because obviously, if there's no tumor growing in there, this dog may well live to die of something else. And as far as strokes go, I would say rule of thumb, about half the time, we can find a cause for the stroke. So revisit that discretionary database, because the discretionary database for stroke investigation is much the same as for seizure investigation. And see if you can find, and half the time you will find something that triggered that stroke. Perhaps the only thing I don't have on there would be cortisol. Can't remember if I put that on there. So cortisol, so Addison's, Cushing's can also alter coagulability. Yeah. Okay. Does that answer your question?
And so if you look at it, you don't find an underlying cause, what would your drug of choice be?
Regardless of the underlying cause, I would treat, and I would start with phenobarbital if the liver could tolerate it. Based on the levels of evidence that I presented, it has the strongest evidence behind it, the strongest recommendation behind it, and as long as the owners are educated as to expected adverse effects, and the liver is in a state that it can process the phenobarb, that is the drug most likely to help achieve some sort of control of the seizures.
And what if the sedation by the phenobarb causes the dog respiratory distress because it barely has an airway?
So, turn off the camera for a moment. No, just kidding. So we have a collapsing airway tracheal elixir here at OVC that actually has phenobarb in it. So we use it as a sedative, the barbiturate as a sedative, to relax their brachycephalic airways. So the situation you're facing there is where phenobarbital's adverse effects are intolerable to the dog. And if that's the case, you have to move to something else, because obviously breathing trumps seizures. That's how I see the world. So breathing trumps seizures. And in that case, I would recommend something like zonisamide or levetiracetam. Yeah, depending on lifestyle, can they dose it Q8 for levetiracetam, expense because of cost of compounding, that kind of thing. So it's factors to consider. Good luck with that. Yes?
Is that involved in doing an EEG appellants?
Good question. Absolutely. So what is involved in doing an EEG? How does the procedure occur? What's the cost? That sort of thing. An EEG is like doing a 12-lead ECG. Okay. So some animals you would have to knock out to get all 12 leads on. Some animals will just stand there while you put the electrodes on. Okay. So from placing the electrodes, that's a 12-lead. We're essentially putting 12 electrodes on the scalp. We attach them with sticky bandage, and then vet wrap, and then an e-collar if we need to. And like I said, some dogs or some cats need to be sedated before we do all that. For dogs that are the right size, the EEG currently works as a backpack. So they wear a little Holter monitor jacket with a backpack monitor, and then they're wireless. they're instrumented in wireless. They can wake up, they can run around, and I will record until they get the EEG off, which for some dogs, I think the shortest time period I have, no, actually, the cats were worse. 20 minutes for a cat. Dogs, I've gotten at least an hour typically. I then take that data and I review it, and I'm looking for paroxysmal brain activity. So my EEG is that microphone I've lowered into the stadium. And I'm looking for the VPCs, basically. I'm looking for all the neurons doing the same thing, producing a recognizable wave. And in fact, when I'm training the anesthesia techs and the ICU techs, I tell them, if you see strings of VPCs on my EEG, call me, because that's not normal. Normal brain should actually be just a lot of static fuzz. So that's how we do it. It can occur as an outpatient procedure. So we have, owners see them as an appointment in the morning. They're like, yeah, actually, we'd like to know, see if, and the frequency is enough that we think we could catch an event this afternoon. Then we will admit them for the afternoon and instrument them, have them hang out with a fourth-year student. Really helpful, those fourth-year students. Have them hang out with a fourth-year student for the afternoon, and then pull everything off and send them home at the end of the day. For those with slightly longer interictal periods, what we recommend is trying to catch some natural sleep. Remember what I said about the sleepy brain being more likely to do abnormal things. So those ones we might admit overnight and have them hang out in the ICU with the camera on them and let them go through that hopefully natural sleep process. Sometimes the ICU is a busy place and we don't always get the best sleep in there. But typically within about 24 hours, we'll get our answer one way or the other. For those that are having 2 or 3 events a year, I tell people we can see if the brain does interictal abnormalities while they're snoozing, but they don't always show that, so it's a bit more of a fishing trip at that point. Cost-wise, there's the appointment fee, so our standard neurology referral fee, I believe, is $175. Yeah, Jen Collins, our technician, knows all these numbers because she is the one who quotes them to you. And then we have a short EEG, which is sort of that afternoon procedure, of a $250. We have the overnight, so anything more than 2 hours running into the overnight to multiple days, because we will monitor some of our ICU patients for multiple days when they're coming out of a bad coma for whatever reason, brain trauma, other causes, metabolic causes of coma, that sort of thing. We will monitor them multiple days. So we do have a first day $485 fee, kind of up there with an ultrasound, like abdominal ultrasound cost. And then there's a tack on for every 24 hours thereafter. I think it's like $200, $250 if they're in the ICU and we're just sort of serially monitoring them. Then there may be, like I said, a sedation and reversal in there, depending how excited the pet is about having all this gear put on. Does that answer your question? Oh, and then if they're in the ICU, there's the ICU cost. So I think that they tend to charge for the less exciting ones. I think it's about $120 for every 12 hours or so.
It's too expensive to send a dog home to have it sleep at home.
So I have experimentally tried that in, well, the first dog I followed home with the gear. That was a special case because the gear itself is tens of thousands of dollars. And then with a particularly good client, we sent it home twice. And we're in the process of looking at how we can set it up as a rental Holter monitor unit. Does that make sense? Where that's not hammered out yet, and yeah, that's absolutely, that's the ultimate goal. And the equipment we have right now records for 96 hours straight. So we could instrument on a Friday afternoon, send it home, bring it back in on Monday, and strip it off, and then read it. Okay. So our long-term goal is the neuro Holter, basically. We're just, there's some processes we're still sorting out. Yeah. Other questions? Yes. First line of treatment for cats is still phenobarbital for me. I start with 7.5 mg per cat Q12 and work from there. If 7.5 mg per cat Q12 works, I don't check levels. If it doesn't work for whatever reason, if the cat is stoned or the cat is still having seizures, then I'll check a level and adjust as appropriate. Yeah. Per cat, 7.5, so half a 15 mg tab Q12 per cat. Yeah. I mean, they're all roughly the same.
And if there's multimodal therapy in dogs, we start using the pills still.
So multimodal therapy in dogs.
And then add from there whatever you think is appropriate.
Right. So the question is, for multimodal therapy in dogs, do we start with pheno and add from there? Ideally, yes. Reality is I start with whatever you sent them in on and add from there. Sometimes for example, they come in on Keppra, levetiracetam, and the reason was they tried pheno and they didn't like how sedate they were, and so they gave up within 3 or 4 days. And so sometimes we will revisit that question and say, okay, look, if we push through, the sedation should go away within the first 2 weeks. And so if you can get through those first 2 weeks and you're still not happy, then we'll take it away again, but maybe we should give it a bit more time. I often end up having to put animals on more tertiary, what we would consider tertiary level drugs like Zoni or levetiracetam, because I don't see the routine cases, again, that you guys see. I see the complex ones where the liver's packing it in or the kidneys aren't working, or, you know, like there's a whole host of ancillary problems that we're trying to juggle. And so I tell the 4th years as well, what I suggest to you isn't necessarily what I always do, and because of that reason. So same comment to you. That said, we are open for questions, okay? So if you have a case question and they really won't refer, but you're like, you know, write down the details, fax it into us. We try and call you back within 24 hours is our goal. And we try and help you with your cases. So we are very friendly about that. Don't hesitate to send along the question. Yeah. The more urgent ones we will call back on the spot, depending on what's going on. So I have given advice to several status cases, for example, where the owner's like, yeah, we can't go anywhere. Can you fix it? And so we'll call in and say, okay, these are your options. Try this, try that. Yeah. Other questions? Yes.
You had recommendations for dogs when to do an MRI. What about cats? What would you recommend cat methods?
Very good question. So the question is, we have recommendations for what to do about cats, dogs. The question is, what do we do about cats as far as MRI imaging? You all willing to sit still for another 10 minutes? Okay. I have some slides on cats, if you wish to see. And I can show those to you very quickly. One of my happy places. It is a beach called Bethel's Beach, north of Auckland in New Zealand. For those of you who detect a slight accent, I went to high school in New Zealand. Okay, the slides are just loading. Okay, so these slides, there are some videos which I'm going to have to skip over very rapidly. Actually, I can probably just delete it. Hang on. I don't have permission to show these videos today. Oh yeah, here we go. So this is the statistics on cats. So 2010, Journal of Feline Medicine and Surgery, a study was published that showed that 40% of cats have genetic epilepsy, probable genetic epilepsy, so the suspected range. We haven't actually done the breed studies or found a gene, but these are the idiopathic epileptics of the cat world. And it's actually 40%, which is higher than most of us thought, because we'd previously taught that cats don't have seizures for fun. Well, 40% of them do. However, if they present with status epilepticus, or they're greater than 7 years of age, or they're abnormal interictally, you should be doing an MRI. Okay, this is not idiopathic epilepsy. And I would go on to say if they're not responding to treatment, you should consider an MRI. Okay, 11%. So of the 40%, not of the 40%, like an additional 11% have something called hippocampal necrosis. And this was the cat case I mentioned in response to the question over here earlier. And these are the ones who have those orofacial signs that you've seen cats do. And absences, where the cat just sort of spaces out. Now, I know some cats just do that for fun, but no, I'm talking abnormal spacing out, staring into the distance. And the hippocampal necrosis ones tend to present as an acute cluster of seizures. So I apologize, these aren't in your notes. This is from a separate lecture. But that should answer your question?
Yes.
Good. So there's two J feline med surge. One is 2010, one's 2011. Referenced there. Other questions? Yes.
Your thought on chiropractors?
My thought on chiropractors. It depends on the kind of chiropractor. Chiropractic, as defined by adjustment of subluxations that interfere with the flow of nerves that control, well, they say nerves, but control everything in the body, it does not exist. The evidence shows that that does not exist. If you're talking about chiropractic as spinal manipulative therapy, that is an effective treatment. Not for seizures, though. It is an effective treatment in humans for low back pain. That's my thought on chiropractic. There is no evidence that chiropractic can in any way, whichever field of chiropractic you subscribe to, there is no evidence that it can affect seizures or epilepsy control. Yes?
In sport dogs, do you have a recommended combination multimodal therapy that makes them most functional?
Good question. That's another one I see a lot of the time. So the question is, in sport dogs or working dogs, is there a recommended therapy, multimodal or even monotherapy, that can control things without affecting their ability? Short answer, no. Long answer, possibly. The pheno is often the most effective, but you're riding a fine line, a knife edge, between delayed reflexes and response times and gait changes and mentation changes and actual control, successful control of the seizures. However you wish to define that control, whether it's seizure freedom or partial therapeutic success. I have faced this question practically and often recommended, because they came in on pheno and were not happy about that fine line, tried to manage them with adjunctive medications. We have considered levetiracetam, zonisamide, pregabalin, and gabapentin. And then the other thing I will do in multimodal, and this is a more general response, in multimodal therapy, where interictally all the drugs are making them too stoned, we actually will scale back on the drugs interictally and do what we call cluster management. So we'll leave them on pheno at a dose that keeps them functional, but then when their clusters occur, because a lot of these sport dogs are border collies and German shepherds, and they all tend to cluster or status, what we'll do is manage the status and cluster with a whole host of those adjunct drugs. They have short enough half-lines that you can try to pulse dose them. Is this evidence-based? No. Is it effective? Maybe. I'm not willing to, I say to the owner, I'm going to hold hands with you and jump off the cliff together. Let's see how this works. There are a small proportion of dogs that we will discover respond really well to one of these adjunct drugs. And so I've had, for example, one poodle, after years and years, the liver could no longer tolerate the phenobarb. We had to take it off the phenobarb. We put it on levetiracetam. That didn't work. So we switched, again, half-life is short enough that we can do a fairly rapid turnover. Switched it to gabapentin. That didn't work. Switched it to pregabalin, and didn't see the dog again for 3 years. And last time they called in, they're like, we've taken him off his drugs. He's doing fine. So I don't know if he grew out of it eventually, like, so he went into remission spontaneously, naturally, or whether our drugs put him into remission. That's just sort of an example of what we might have had to do. Yeah. That said, I have police dogs out there who are working just fine, and there are police dogs that were retired because they just couldn't tolerate the drugs. Yes?
Are they sort of very specific versions, or can they be just kind of brand anything? The reason why I'm asking is I have a mother cat who's got 2 kittens, and all 3 of them do the same thing. And they kind of do this funny little cross between a chomp and a smack, and all 3 of them do it.
So the question is, the orofacial signs for cats, how typical are they? And the reason being is the member in the audience here has a mom cat and kittens that are all doing the same thing. In the reports, they seem to be associated with this hippocampal necrosis. In practical reality, I've seen cases that aren't hippocampal necrosis that have these fits, and they look like they're chewing gum or trying to spit out their tongue. I've seen more subtle ones as well, where it's just some twitching of the muzzle at the base of the whiskers, and drooling, and pupillary dilation, and an absence. I've seen it where it's just drooling and circling and peeing. I think the more that I look at and try to record EEG on, the more I'm discovering that things I might have dismissed earlier as not seizure are maybe actually seizure. And I would have a very strong professional curiosity in seeing this family of cats of yours. Let's put it that way. Yeah. Good for you. Yeah. Yeah. Email me a video for what the video is worth. Yeah. Yeah. Yes.
When you see these animals that go into remission, how soon after, on an average, do you see symptoms return, or do they?
So the question is, for the animals that go into remission, how soon after do the symptoms return? In the literature, a percentage of them do. I think it's in the teens or 20s, if I recall correctly. Personally, of course, my sample is hugely biased, right? I'm not going to see the easy cases. So in fact, I would be very curious, like I said, to turn that question back to you and say, how many have you seen go into remission? I've had only a few graduate from my program. Because, and again, some of those I'm not sure if it was old age that allowed them to graduate, almost that they literally grew out of it, or that with the decrepitude of the brain that comes with old age, that maybe they lost sufficient neurons that they could no longer propagate the pattern. I don't know. The ones I've seen haven't come back to me yet. And I've been practicing as a in neurology for almost 10 years now. So, yeah. So if they have, and you're just not telling me, that's another possibility. That Fiona James. Yeah. Yeah. Other questions? Yes.
I have a cat at home. He gets very, very excited and he begins to open mouth barking, and then he almost attacks the wall or attacks nothing. And I'll talk to him, and he's not really aware of me. I'm not sure what's going on. It's just very weird. And he's very young. He's only about 6 months old. Okay, so the question is cats with other presentations, basically, of seizures. The description fits with, certainly we've had cases where we were suspicious. I haven't had the pleasure of recording one yet, where we've been suspicious, cats and dogs, that these rage episodes are seizures. I had one cat, this was before I had an EEG that would work on the cat, it turned out it was probably something like acute Cerebra infestation, so not your cat, but had presented for rage episodes, and MRI showed, patchy abnormalities in the brain. So those rage episodes could well have been a manifestation of seizure, and it turns out on histopath that the patchy inflammation in the brain was very eosinophilic, and so could have been, we never actually found the larva, but we were chasing it, is probably the best way to look at it. So I would consider that possibility. Yeah. EEG has just basically made me a lot more open to certain things being epileptic that I would not have considered before. Other questions? No? Well, I would thank you very much for your patience tonight. Hopefully this was helpful. Thank you again to our sponsors, too.